Sir, we are good to start, sir.
Good evening, everyone. We welcome to weekly webinar organized by Yashoda Hospitals in association with SEMI India. So this week, the speaker is Dr. Kiran Varma, this is my colleague, heading Department of Emergency Medicine at Somajiguda. So Kiran, you can take over now.
Yeah, thank you, Dr. Raghu, sir. Thanks for a nice intro. So, good evening, one and all. Myself, Dr. Kiran Varma, working as head of the department emergency, Yashoda Hospitals, Somajiguda. So, today we are here to discuss something about interesting exercise and CTs. So, before I'm going to start my talk, just to keep one thing in mind. So, this is not a class or something else to discuss in detail about how to read X-ray, how to read CT scan, then how to approach a case, what is the ABCD approach. So we are not going to deal about those things. So it will be like interactive session, what we want to make it today. So like a scenario based. So we'll give you the scenarios, then differential diagnosis, then how CT and X-ray are going to help us. So how to pick up the points or how to pick up the diagnosis by looking at CT and X-rays. So this is how it goes today. Okay, let me share the screen. This one, right? So that is how it goes today. So I will start with first scenario. This is the scenario one. So 55 years old male brought to ED with early history of RTA and sustained injury to the chest and abdomen, having breathing difficulty and pain in the chest and abdomen. So ABCD, we are not going to discuss about ABCD, all those things. I will give you the only things which are required for our session today. So pulse rate 130, respiratory rate 35 per minute, BP 80/60 mmHg, saturation is 60% at room air. On examination, respiratory system, absent breath sounds on right side and hyperresonant node present. On abdominal examination, multiple contusions and grazed abrasions over the abdomen. So in this, so what are the clues we get to have a diagnosis in our mind? So one thing is like RTA, then having breathing difficulty, pain in the chest, then BP was low, saturation is also low. Then when you look at our respiratory system examination, absent breath sounds on right side and hyperresonant node. So what do you think about it? So when such scenarios comes, first thing what we strike in our mind is like pneumothorax. So what kind of pneumothorax? Again, based on vitals, BP 80/60. Now we can think that tension pneumothorax. So by keeping pneumothorax in the mind, we have done the chest X-ray. So moreover, chest X-ray also is not required to confirm the diagnosis of pneumothorax. So okay, we have done. So did you find anything over here? So which side you where is abnormality, right side or left side? So if you look at the X-ray, especially on right side, just focus on the right side. Can you see the demarcation here? So this is lung tissue. This is lung tissue. Then rest of the part is like a air. I mean pneumothorax. So pneumothorax is compressing the lung. If you see the other side, you can see the clear bronchovascular markings. So this is how you have to differentiate between normal lung and pneumothorax. So here are the bronchovascular markings. If you look at on right side, there are absence of bronchovascular markings. So it means that it is a pneumothorax. To know whether it is a tension pneumothorax or a simple pneumothorax, again it's based on hemodynamic status. In this patient, BP was around 80/60. So we can tell it is a tension pneumothorax. So as you know what to do when there is a tension pneumothorax, first to needle decompression followed by ICD. So that we are not going to discuss in detail about. So in this X-ray, are you able to differentiate between normal lung and pneumothorax lung? So one thing you have to remember here, bronchovascular markings. When there is absence of bronchovascular markings, then you can suspect pneumothorax. So as we all know that focus point of care ultrasound, so it is our point of interest as well. So when you do EFAS on the same patient, you can see the barcode sign. Just for the comparison, I mentioned this one. So this is, which is you are seeing on the left side of your screen. This is C-short sign, which is normal. Then right side, this is barcode sign. The same patient. This is the lung tissue, lung margin. Then rest of it like a pneumothorax. Then the same patient was having abdominal, pain in the abdomen. Then BP was again like 80/60. So on abdominal examination, multiple contusions and graze rupture over the abdomen. Here the clues like RTA, pain in the abdomen, BP was low. On parabdominal examination, multiple contusions and graze rupture over abdomen. So in this patient, what do you think? There may be free fluid secondary to the visceral organ damage. If you look at the BP, 80/60 is hypotensive. So might be thinking free fluid in the abdomen, in the background RTA. So we can suspect it is a hemorrhage, blood in the peritoneal cavity. So what we do in our ER, when you see a patient with RTA, abdominal injury, we do the fast scan. So if you look at here, this is hepatorenal pouch, normal. When you look at the splenorenal pouch, you can see the free fluid. This is the spleen. This is kidney. This is splenorenal pouch. Can you see the free fluid here? Hypoechoic. This is hypoechoic. Sorry. This is free fluid in the splenorenal pouch. Then you can see the free fluid here as well. Then free fluid in the pouch of Douglas. Then when you do the CT scan, so this is the CT scan findings. Spleen, you can see the spleen is shattered. Spleen is shattered. This is the spleen, this is the blood in between, clots in between the splenic tissue. So this is how we can get the clue in the CT scan when patient has splenic laceration or splenic injury. So first one is history, where you get the clues. Then our ultrasound, point of care ultrasound fast scan. So there it is. You can see the fluid here. Then which is evident in CT scan. See what do you find? Splenic laceration. Then scenario 2. A 32 years young female with alleged history of fall from height about 20 feet. Since then she was unconscious. Then her GCS was like E1, V1, M2. And people 4 mm both sides are non-reacting to light. Then there is a palpable skull fracture of the left frontal region and she is hemodynamically stable. No other external injuries. So with the history, so clues are like fall from height about 20 feet, which is significant height. Then she became unconscious. Then her GCS on lower side E1, V1, M2. Pupils 4 mm both sides, non-reacting to light. That means pupils are fixed. Then palpable fracture over the left frontal region examination. So the things which are mentioned in the red color, red color, it gives you the clue. Then what do we suspect? We suspect head injury. Since there is a low GCS and pupils are fixed and there is a palpable fracture on examination and other external injuries as well. When you do the CT scan, so these are the findings. See, you see it in the upper left corner. This is one CT in the same patient. Right upper corner. So another film, then lower films. So first we'll discuss about this one. Can anyone guess what it is? So if you guess, if you type the answer correctly, if at all you want to talk, you just raise your hand, we will give the permission to talk. So here I would like to announce one thing. The first 3 people, those who are going to answer correctly more than twice or thrice, you will get a free conference permission, which is going to be conducted from down the line 2 to 3 months. So I'll get all the details of the persons who who answer correctly. Then I'll give you the free conference pass. Okay. If at all you want to raise your hand, please raise your hand. We will give you the permissions. So major type of telling that it's like a SDH. Then, so why you are thinking in terms of SDH? So how do you differentiate between SDH and EDH? Yes. So can anyone tell me how do you differentiate between SDH and EDH? Preeti Aklanti raised hand. Please make her to talk. Admin. Admin, please make her to talk. Preeti Alikanti raised hand.
Sir, she need to unmute, sir.
What?
She need to unmute, sir. I'm asking to unmute.
Ma, please unmute.
Preeti should unmute to speak.
Okay, there are many answers like SDH, I mean concave, convex. So first best answer is SDH will not, see SDH will cross the suture line. So if you see other side, this is EDH. EDH will not cross the suture line. SDH will cross the suture line. But when we used when we are doing our PG period, we used to remember like this. EDH means biconvex and idli shaped. So SDH is like a dosa shape. But when you go for example, don't write like this. So when you ask difference, you should tell like SDH will not cross the suture line. SDH will cross the suture line. EDH will not cross the suture line. But EDH also will cross the suture line when there is a fractured suture line. So that is the only one condition where EDH can cross the suture line. If you look at the down CT films, you can see the depressed skull fractures, the left frontal region. So here I would like to answer one more question. So when do you say it is a significant depressed skull fracture, or when it requires elevation or surgical intervention? So all depressed skull fractures are not significant. All might not require surgical correction. So to say it is a significant depressed skull fracture, so what is the criteria? When you say it is a significant depressed skull fracture, anyone wants to raise your hand, anyone wants to talk, so that we will permit you to talk. Some people are telling that air fluids, no? Frontal skull fracture, okay. When do you call it significant depressed skull fracture? CSF leak, to a certain extent, but that is not the best answer. Edema, no. Or we can see a bony depression. Bony depression, yes. That itself is a depressed skull fracture, right? Bleeding, no. So you should compare with the adjacent skull. Depressed skull fracture, if you want to say it is a significant depressed skull fracture, the depressed skull depression should be more than 1/2 of the depth of the skull, mean outer table, inner table. Example, outer inner table depth is like 4 centimeters. The depression should be more than 2 centimeters. So then only it is significant, which requires surgical repair or correction. Okay. So majority of the people answered wrongly. Okay, good, no problem. So we'll move on to the next one. Scenario 3. 61 years old male who was known case of diabetic, hypertensive, rheumatoid arthritis on pain medication from last 6 months. So brought to ED with history of severe abdominal pain and vomiting followed by fever from the last 3 days. So here are clues in the history. Clues are like rheumatoid arthritis on pain medication from last 6 months. Brought to ED with history of severe abdominal pain and vomiting, followed by fever from last 3 days. On general physical examination, he was showing like toxic look. Then temperature was 102 Fahrenheit, pulse rate 110 per minute, BP 110/60. Per abdominal examination, a diffuse tenderness present, guarding rigidity present, bowel sounds are obscured. So what could be the differential diagnosis here with the history? Clues are like pain medication from last 6 months, severe abdominal pain followed by vomiting, and fever from the last 3 days. And he was on toxic look. Then abdomen like tender, guarding rigidity present, bowel sounds are obscured. Perforation, peritonitis, intestinal obstruction, perforation, good. Perforation, excellent. So yeah, by keeping all these differential diagnosis in the mind, so we have done the X-ray erect abdomen. So this is the X-ray. So what do you suggest? So what are your findings here in the X-ray? SAO less likely. Yes. Adil. Air under diaphragm. Yes. Any other? Yes. Pneumoperitoneum. Good. Preeti. Sandeep. Ground glass. Okay. Good. So yeah, I think majority people on the track. So we're so happy for it. So it is nothing but perforation. Okay. Perforation. See, this is the clue. This is air under diaphragm. This is air under diaphragm. So perforation leading to peritonitis. So that might be the reason for toxic look, having high temperature, all these things. So always you look for, when you are taking X-ray erect abdomen, patient should be stable. I mean hemodynamically stable. If patient is not hemodynamically stable, don't allow him to go for the X-ray erect abdomen. Example, same kind of history, or suspecting peritonitis with perforation with peritonitis. BP was low, I mean hemodynamically unstable. So do you allow him to go for the X-ray erect abdomen? How many of you say yes? If you say no, Aisha, what is the reason? Then what do you do? So which type of X-ray you want to do now? Rescue and ship to OT? No. Okay, you have to do registration. That's for sure. Arrest. Decubitus, Usha Bade. Decubitus means what? You're right. Yeah, given half of the answer. Yes, exactly, Vinayak. What you do, correct. Left lateral decubitus. Left lateral decubitus X-ray. Okay. So when patient is unstable, don't subject him to go for the X-ray abdomen, but subject him for the lateral decubitus X-ray. So can you see it here? This is air. This is the air. Now you can make out the difference. Oh, it is low. It is not moving. Sorry. Gas stuck somewhere. So there is a technical glitch. Just hold on. Please bear with us for 1 minute. So there is a technical glitch. Yes, now it is okay. Yes. Now, can you see the difference now? This is air under diaphragm. So this is lateral decubitus X-ray. You can see the air. Then fourth one. A 42-year young female, known case of diabetes and a status post-splenectomy about 7 years ago, and presented with history of abdominal pain and distension, recurrent bilious vomiting, no passing of stools and flatus from last 2 days, hemodynamically stable, abdominal examination, it was distended, visible peristaltic waves, and hyperactive bowel sounds. So what do you think? Saurabh, pseudo obstruction. Sandeep, SAO. Usha, intestinal obstruction. Hello. Okay, 5 minutes, half an hour meeting. It's SAO. Why SAO? 1 plus intestinal obstruction. It's good. So by keeping all these differential diagnoses, we had done the X-ray abdomen. I think there's a problem with the internet or laptop. Yes, this is the X-ray. X-ray abdomen. So what do you think? What do you think about this X-ray? Just keep everything in the mind, including history, clinical examinations, then X-ray. It is a cumulative effect, right? So don't jump onto the diagnosis by taking history alone. It is, you have to consider all these things before coming to the diagnosis. Intestinal obstruction. Exactly, this is intestinal obstruction. So is it large bowel obstruction or small bowel obstruction? Large bowel or small bowel? No, that is not coffee bean. No, that's not coffee bean. So people are telling us the large. Mainika, Ayesha, Usha, small. So first of all, you should know how to differentiate between small bowel obstruction, large bowel obstruction, especially in X-ray findings. When it comes to small bowel, it is located in the center. When it comes to large bowel, it is in the periphery. That is location-wise. Then the best one is like valvular inconvenience. So that will be present in the small bowel. See here, you can see the lines, right? To extend from one to another end. So this is plicae circularis or valvular convenitis. So these are the things. It will be extending from this end to this end. These are called plica circulare. This will be present in the small bowel obstruction. In case of large bowel, haustra might be present. Haustra. So this is how we have to differentiate between small bowel or large bowel. Small bowel is location-wise center. Then plica circularis will be present. Then in case of large, it is a peripheral. Haustra will be present. Cecal obstruction. Can see the convenitis. Very good. You can see it. You can see it, right? The circular lane. I mean, one lane which is traveling across the lumen. See here also you can see small lines. These are the lines. So these are the lines. So these are the lines. This is how you will differentiate. Good. So then another one, scenario 5. A 65 years old female presented to ED with complaints of abdominal pain, distension abdomen, bloody diarrhea, fever, and tiredness from last 5 days. Temperature 1 or 2, just note it down. Pulse rate 120. So there is a tachycardia and hypotension and tachypnea. Saturation is like 19% room air. So an abdominal examination, it was distended, tenderness present, sluggish bowel sounds. So any differential diagnosis? Diverticulitis, toxic megacolon, Washabade, Adilafsal, mesenteric ischemia. Good. Yes. So keeping all these differential diagnoses in mind, we have done the X-ray. The problem is the X-ray. Yes, this is the X-ray. So this history, abdominal distension, bloody diarrhea, fever, tiredness, tachycardia, tachypnea, hypotension, then abdominal findings. This is the X-ray, followed by CT. So what do you think? Adil Afzal, Kori toxic megacolon, mesenteric ischemia. Usha Bandi toxic. Large colon dilated, very good. So this is nothing but toxic megacolon. This is toxic megacolon. Okay, no problem. Sorry for the typo. Don't worry, Usha. You are on track only. You're right. See, you can see the distinction of colon. So obviously there will be no obstruction at all. There will be a dilatation of the colon. So this is toxic megacolon. Why we are calling it toxic megacolon? If you go back to the history, so patient is having fever, then sepsis, feature tachycardia, tachypnea, hypotension. So with the dilated bowel loops, colon, this is toxic megacolon. If patient was not having history of fever, toxic look and all, it might goes in favor of intestinal obstruction, large bowel obstruction. See, you don't find anything here, like a plica circularis and all, located peripherally. That's when you are reading any image, compare with the history. Without looking at the history and clinical findings, don't jump onto the diagnosis. Yes, sepsis increased. Sepsis second, toxic megacolon only. You're right. In the CT also dilated bowel loops. This is the scenario 6. 27 years young boy with early history of RTA, skid and fall from bike, subsequently run over by auto rickshaw, and sustained injury over his pelvis. Patient was confused, diaphoretic, pulse rate was around 130 per minute, respiratory rate 30 per minute, BP not recordable, saturation not detectable, pelvis on examination tire marks present, pelvic compression followed by destruction, pelvis looks unstable. No other injuries. What do you think? Pelvic bone fracture. So he is in which classification of hemorrhagic shock? Class 1, Class 2, Class 4? Class 4. You're right. Usha, Ayesha, Ainika, one place, Sat, Bhavita, Anu, Reshma, Sayed. Yes, you are right. Class 4 hemorrhagic shock. So we have done the X-ray. Yes, there's a problem with the computer, I think. So this is the X-ray. So what is your diagnosis now? By looking at this X-ray. Then you have to think about types of pelvis fracture. Yes, open book fracture. Ashok, you're right. Rajesh, open book fracture. Diastasis, Reshma side, open book. Now you can see the different, distance here. Then you can see the fracture over here. L of sacrum. So this is open book fracture. So which might be leading to hemorrhagic shock. Usha, pelvic diastasis. You're right. So majority of the people answering correctly. Then I will go to the scenario 7. A 45 years old male, known case of pulmonary tuberculosis, presented to ED with left side chest discomfort and breathing difficulty, which is progressive gradually. Pulse rate 100 per minute, respirator 34 minute, BP 150 by 60, saturation 85% at room air, RS, reduced air entry and left lower chest, and dull knot and percussion. So these are the clues which is marked in red color. Pulmonary tuberculosis, left side chest pain, breathing difficulty, which is not sudden, which is progressive gradually, then low saturation, then RS, reduced air entry and left lower chest, and dull knot and percussion. So with this history, what do you think? Pleural effusion. Yes, pleural effusion, Bhavita, Reshma, Dr. Baba, Sandeep, G, 1 plus. Consolidation, okay. Yes, consolidation, one of the differential diagnosis for this. Pneumonia, yes. Effusion cap. This is the X-ray. So what do you think? Hello. So what is your diagnosis? History and X-ray fine, come in both. So what do you think? Is it consolidation or effusion? Yes, effusion. Adil Afsal, Aisha, Vivo 2151. Oh, mobile company. Dr. Baba, Anu. Yes, it is pleural effusion. So how we are going to differentiate between a pneumonia and pleural effusion? Only a single word answer. So there is no obliteration of, there is obliteration of costophrenic angle on the left side. So that itself is alone to say it is a pleural effusion on left side. Why pleural effusion? Secondary to tuberculosis. Then you should read about types of pleural, types of pleural effusions. Then you have to read about Light's criteria as well to know whether it is exudative or not. We are noting it down. Dull notracheal shift, obliteration, CP angle, superb. Adil Afsal. True. Here bilateral, left more than right. You're right. Yes, we are noting down overall answer because we have to give 3 passes for conference, right? Where we are doing we are on the job. So any other inputs from your side? So what about trachea? Okay, good. Now we'll move on to scenario 8. So a 55 years old female, diabetic, hypertensive, underwent proximal ureter stenting. Then, she developed fever, frequency of maturation, cough followed by SOB. So here clues are like he underwent surgery, some surgery, urological surgery. Then she developed fever, frequency of maturation. It means that he might have developed UTI, urosepsis, then followed by cough and SOB. On examination, temperature 103, pulse rate 110, respirator 36, low saturation 65% room air, BP was holding 100/60. RS examination, bilateral crack is present. So these are the clues. One is surgery, urological surgery, then developed fever, frequency of maturation, tachycardia, tachypnea, temperature is high, low saturation, RS examination, bilateral crack is. So what are the differentials here? Stent block causing back pressure UTI, then why SOB and cough and SOB? Yeah, DS Vivo 125, I don't know the name. Usha Bade, okay, ARDS, Dr. Ayusha, fluid overload. Any edema, 1 plus? No. Okay, might be. That's why we have to keep as many differentials as possible with the history itself, history and clinical examination. Diaphragmatic injury, okay. He underwent urological surgery, ureteric stenting. Less likely to have diaphragmatic injury. Okay, other possibilities. Sepsis, fever, status post stent. Yes. Then any other better answers? Urosepsis, REMA. Urosepsis and ARDS. Then Dr. Rimi, pulmonary embolism and ARDS. So with that history and clinical examination, so we'd like to do X-ray, aspiration pneumonia, RIMI, urosepsis, stent plaque, post-operative atelectasis, Ushabade. Then you have to do brainstorming. So this is the time for brainstorming. Everything is there, not brain. Only thing is we don't know how to take it out. Good, nice interaction is going on. So different thought process, different diagnoses. So we are getting as many differentials as possible. Now we had in the chest X-ray. So we got one more answer here. Pneumonia, pulmonary edema, urosepsis, renal failure, urosepsis. So this is the X-ray. So now you tell me what is the diagnosis? Fluid overload, ARDS, Saurabh, Vinayak, pulmonary edema, Sandeep G, Sweta, Swati, ARDS, Rajesh, fluid overload, Aisha, respiratory failure, pulmonary edema. Good. So now majority of the people going in favor of pulmonary edema and ARDS. I mean pulmonary edema secondary to fluid overload state. Now this is a picture of ARDS. This is not a pulmonary edema. Now I would like to ask, how do you differentiate between these two, ARDS chest X-ray and pulmonary edema chest X-ray? So how do you differentiate between these two? If you know the differences, then you battering seen in Sandeep G. Cotton wool appearance, or yes, battering, heart size. This is the AP view. In AP view, we will not comment on heart size. Yes, Preeti, pulmonary edema, battering. Vivo view, 2-1-2-1, cotton wool appearance. Yes. This is pulmonary. This is not a pulmonary edema. This is ARDS. You see, you can see the infiltrates. Diffuse and bilateral infiltrates. This is a picture of ARDS. Then if at all you want to differentiate between these two, then you should know about pulmonary edema picture as well. Pulmonary edema usually located in the central, bilateral, perihilar region. So it gives appearance of battering. So battering appearance goes in favor of pulmonary edema. Then picture like this, it is a diffuse, not only located in the center, but it is also scattered in the peripheral zones. So cotton woolly spots. So this goes in favor of ARDS. Then where do you see curly B lines? Where do you see curly B lines? Pulmonary edema or ARDS? Curly B lines, correct. Curly B lines in pulmonary edema. Then here I would like to ask one more question, since we are talking about pulmonary edema. What is phantom's tumor? Phantom's tumor. Phantom, PHANTMOR, phantom's tumor. Any answers for phantom tumor? Yes, vanishing tumor in pulmonary edema. Here, this is the picture of battering sign. It is located in the center and perihilar. It gives picture of battering sign. So when it comes to phantom tumor, so it is not a tumor, again it's due to pulmonary edema, because fluid will be located at certain areas like fissures and all. It appears as a tumor. So it's why that's why it is called as phantom tumor. Okay. Now, are you able to differentiate between these two, ARDS and pulmonary edema secondary fluid overload? Simple. Pulmonary edema is like a central and perihilar. It gives appearance of batwing. Kerley B-lines will be present in case of pulmonary edema secondary to fluid overload state. Might be of any other reason, CHF as well. In case of ARDS, it is diffuse and not only in the center but also located in the peripheries. It gives infiltrates kind of thing, cotton woolly spots. So that is how you have to differentiate between ARDS and pulmonary edema secondary to any of the reasons. Kerley B-lines will be absent in the ARDS as well. Then sometimes if it is a pulmonary edema secondary to CHF or renal failure, you can see pleural effusions along with pulmonary edema. So that also goes in favor of pulmonary edema. Yes, I'm noting it down. Pseudotumor, yes, Usha. So you are right. Then we'll move on to the next scenario. I think there's a problem with the system or net connection. Sorry, so there is a technical glitch here. Sorry for it.
Sir, I will share from my end, sir.
Yes, you can do it. I'm unable to change the slide.
Okay, sir.
I don't know, something wrong with the thing. You know, change out. I'm unable to change the slide.
Where is that?
No, you took the control.
Okay, you took the slide. Okay, you took the control. If you could then here there will be an option.
I'm unable to change it.
Sir, నేను షేర్ చేస్తున్నా sir. You can.
Also, previous slide, Kalva. Go to the previous slide. Yes.
So you should take the control.
Move on to the next slide. Yes. Now another one. A 67 years old female presented with history of sudden onset of severe headache and experiencing for the first time. Then there was a neck pain and giddiness as well. So here clue is like sudden onset of severe headache experiencing for the first time. Then comes to Jesus 15/15 normal, pulse rate was normal, respiratory 13, BP 180/60. Then CNS, no neurological examination. No neurological deficits. So what are our differential diagnoses? Yes, my thunderclap, funny, Suryadev SAH, aneurysmal bleed, SAH, Preeti, Reshma, Syed, thunderclap headache, SAH, CVT, migraine, Rimi, Ashok. Yes. Next slide. So this is the CT scan. So keep the history in the mind. Sudden onset of severe headache, which she never experienced before. Then BP, no neurological deficit as such. Then BP was on higher side. So what is your differential diagnosis? As someone said, SAH and CVT. This is the CT finding. So what is the diagnosis now? SAH, subacute arachnoid hemorrhage. So non-traumatic SAH. So what are the gradings of SAH? So you should think about WFNS classification, Hunt-Hess, and Fisher grading. These are the three things you have to keep in the mind. Okay. So then we'll move on to next slide. A 60 years old female, known case of diabetic, presented with weakness of left upper and lower limb slurring of speech and deviation of mouth since 2 hours. So here clue, weakness of left upper and lower limb, slurring of speech and deviation of mouth since 2 hours. GCS normal, BP 190 by 110, that was one of the clue. CNS deviation of mouth present, power in the left upper and lower limb 2 by 5, plantars on left side, extensors. So what do you think? Stroke, ischemic or hemorrhagic? Right MCA, very good. Reshma Said, Rimi stroke, right CVA. Is it right CVA or left CVA? Acute stroke. Good. Next slide. So this is the CT scan. So what do you think? Infarct or hemorrhage? Ischemic stroke or hemorrhagic stroke? So how it appear? How in ischemic stroke appears in CT? Yes, hypodense. This is the right MC territory. Right MC territory. Infarct. Okay. Then how infarct or ischemia appears in DW scan of MRI? Quite contrast to the CT scan. In CT it is hypodense. Then MRI it is like hyperdense. Okay, clear? So history and clinical examination and CT findings. Since it is within 3 hours, CT patient in the window period, he is a candidate for the thrombolysis. Again, area of involvement is more than two-thirds of the hemisphere. These kind of cases might be contraindication for thrombolysis. So when you are going for thrombolysis, you should be done cautiously. No thrombolysis. Very good. Next. Just to show the difference, acute infarct normal. See, if you see, this is the normal brain tissue. This is the hypodense area. So it is infarct. Next. So this is how bleed looks like. You think that same history, CT was done for the same patient. This was the CT. Then what is this? Bleed. CZ bleed. So typical for hypertensive bleed. So it's the hyperdense. The hyperdense area of brain going in favor of bleed. So this is bleed. So now can you differentiate between these two now? Ischemia and bleed? Previous slide. Ischemic stroke. This is ischemic stroke. Next slide. Then this is hemorrhagic. So based on that, treatment itself will be differed. If it is ischemic, treatment is different. Hemorrhagic treatment is different. So you should know the difference. Next slide. A 45 years old female, known case of CA cervix on chemotherapy and radiotherapy. Here clue is CA, cancer on chemo and radio. Brought to ER with history of sudden onset of SOB and chest discomfort. One more clue is sudden onset of SOB and chest discomfort. Pulse rate, tachycardia, tachypnea, low saturations, low BP. Surprisingly, the RS was clear. ECG was showing like S1 Q3 T3 pattern. 2D echoes RAR dilatation. What do you think? So how sensitive ECG for PT? Do you rely on ECG to rule in or rule out of PT? No. Same today echo findings also. It gives you the clue. Okay. It will not what is that? Fix or finalize the diagnosis. What is the gold standard test to detect PT? Gold standard test. Yes, CTPA. Dr. Sandeep. Next slide. So this is CTPA. So can you see it here? The red markings and all. So this is the clot. This is the main triangle, right and left and right. Can you see it, right? Like hypodense kind of thing. This is clot. So now diagnosis is PT, pulmonary thromboembolism. So go back to the previous slide. So how do you classify this PT? Massive, submassive, or non-massive? Yeah, could be saddle thrombus, true. Adil Afzal, true. Sandeep, filling defect, you're right. So why do you say it is a massive? Dr. Saurabh. Yes, it based on hemodynamical stability. It is not about where clot is sitting. It's not about the mass of clot. It's all about hemodynamical instability. If there is unstable, when BP is low, hemodynamical unstable, then only we can classify it as massive. So that is a candidate for thrombolysis. Next. Sorry, this is 13th. A 70-year-old male known case of Marfan syndrome, uncontrolled hypertensive, presented with a history of ripping pain in the chest and radiated him back to side of the chest. Now these are the clues: Marfan syndrome, uncontrolled hypertension, ripping pain in the chest, radiating to back, pulse rate 100, BP left arm 170 by 180, right arm 140 by 160, ECG sinus tachycardia, echo normal. So these are the clues. So what is the differential diagnosis? Aortic dissection. Yes. Next slide. So this is aortic dissection. That's why history and clinical examinations are at most important. History, chest pain radiating to the back. First, you should think about aortic dissection. Then when you are checking the BP on left and right side, if difference is more than 20 mm Hg, it goes in favor of aortic dissection. That's why you have to check BP on both sides. This is the CT. You can see the false lumen. So here is the yellow marking. No? That is the false lumen. Then right side, if you see, dissection from arch of aorta till bifurcation of aorta. So it is coming under which classification of aortic dissection? Stanford, DBAC A. Okay, think about in terms of Stanford. A or B? Stanford A, Adil, right? Rimi, Baba, Aisha. Yes, this is Stanford A. Then next slide. So I think we have come to the conclusion. So these are the things, these are the cases what we see in our day-to-day practice. That's why with this, I want to conclude. Before conclude, I just want to give a take-home message. Always proper history. Get the proper history. Sometimes we tend to miss history in hurry and because of various reasons, but don't tend to forget collecting proper history. Then thorough general physical examination and systemic examination. If it's like CVS, you have to examine CVS thoroughly. CNS, yes, inspection, palpation, percussion, auscultation, CNS, all the things right from conscious coherence, power, tone, bulk, reflexes. That's why general physical examination and systemic examination. Then after collecting history and examination, you have to keep as many differentials possible. Based on that only you have to rule in or rule out, whether it is in or out. Then correlate with your image. Don't go to the investigations or imaging straight away without collecting history and examining and keeping differentials and ruling and rule out. So this is the dictum for ER. For others, it is different. They do investigations after 2 days, 3 days of admission and all. But being an ER, working under high pressure zone, your decision should be like this. Every seconds matters. Every seconds. That's why we have to be on the toes. We should consider all the things, including history, clinical examinations, and imagings. Then come to the diagnosis. Okay. Next slide. So thank you, Ananda. So if you have any doubts, please ask us. We are going to finalize the winners. Then we'll distribute coupons for the next conference. Thank you. Raghu sir.
Yeah, thank you, Kiran. That was a good presentation, which was helpful for the students, covering from, if you take the trauma, correct the contusions, not contusions, EDH, SDH, then the contusion. Then if you come to the abdomen perforation, then the toxic megacolon. Coming to the cerebrovascular accident, the ischemic stroke, the hemorrhagic stroke, and the respiratory system covering the ARDS and the pleural effusion. And one more thing I want to add, in the pulmonary embolism, if you take an X-ray, what all you can see? So X-ray findings, so you have told the ECG, and we have discussed about the CT iotogram. Then
Yes.
if you take the X-ray, we will have the Hampton sign where it should be the wedge shape, and the Westermark sign where there will be a focal oligemia, and the knuckle sign where there will be a prominent pulmonary artery. So just I want to add few things before the session leaves. So all the ERPGs or all the physicians in the ED, so whenever the patient coming with a mild head injury, if the patient is on a blood thinner with no symptoms of anything, kindly do a CT because he is on a blood thinner. The chances of bleed are high. Don't neglect doing a CT scan. And if you find a hypodense area on a CT on a patient with weakness, so the next thing is MRI is suggested to confirm the infarct. So in patients with headache, vomiting, and suspicious for a venous infarct, we go for a CT venogram can be suggested in the patients with MRI contraindications. And bleeds are better picked up by the CT only. And fractures are better picked up by the CT, and adjacent contusions or bleeds can be better picked up by the CT only. And so whenever the patient is restless, agitated with head injury, so it will be very difficult for us to get the CT. So it is better for us with the higher slices, the duration of scan when reduced. So the motion artifacts can be reduced. And for acute abdomen, CT is the gold standard where the mesenteric tears can be picked up. And for minimal pleural effusion, pericardial effusion, CT or ascites, again, CT is the best thing to pick up. And with the CCT abdomen, the zone of transition can be picked up, and even a closed loose obstruction also can be picked up. And when there is a contained perforation, so again, CT plays a major role in picking up even with an adjacent fluid or a fat stranding. So that is from my side. So any questions, Dr. Kiran is ready to take and he will answer you.
Sir, I think so far no questions. Thank you, sir. Thank you, Dr. Raghu, sir. Thank you, Dr. Srinath, sir, for giving us opportunity to educate our emergency fraternity. Thank you, Yashoda Hospitals and SEMI and Anbai Board for your collaboration and for supporting in each and every aspect. Thank you, sir.
Thank you, Kiran. Thank you, Yashoda Hospital. Yashoda Hospital is in front for the academics. So every week we are having a webinar session with different faculties in different zones. So we thank Dr. Srinath sir, Dr. Yashoda Hospital. So Yashoda Hospital is in collaboration with SEMI for all these academics. So any questions, kindly share. Or if no questions, we will wind up. Bye. Good night.
Thank you, sir. Thank you, Ananda.